That's 7-0, enough to get out. We will keep it open for absent members. Returning the gavel to Chair Hernandez as we move to Senator Mitchell's bill, SB 1034, item 4.
Thank you. And item number 4, SB 1034, healthcare coverage. Good afternoon, member, Senator, and please proceed.
Thank you, sir. Let me begin, colleagues, by clarifying the amendments that we've agreed to take that are listed in the committee analysis. I'm taking those. I'd also like to take a couple of technical amendments, which includes just some semantics, replacing educational with academic, replacing experience with the word training. Another amendment is to strike out the language that says, quote, all medically necessary behavioral health treatment shall be covered in all settings, regardless of time or location of delivery. 2, the new language will be, quote, the setting, location, or time of the treatment shall not be used as a reason to deny medically necessary behavioral health treatment. And I believe those are outlined in the analysis. With that said, today I'm here to present SB 1034, a bill that will ensure that children diagnosed with autism have access to medically necessary treatments by removing the 2017 sunset on the requirement for health plans and ensures to provide behavioral health treatments to children with autism. Many of us were here back in 2011 when the pro tem at that time introduced and the bill, SB 946, was signed into law, which requires all health insurance plans to provide coverage for behavioral health treatment for pervasive developmental disorder or autism. The mandate included a sunset to provide an opportunity for the legislature to revisit various issues after receiving guidance from the federal government regarding the implementation of the essential health benefits under the Affordable Care Act. The federal government has since provided guidance on the EHBs and determined that this treatment is covered under California and the federal mental health parity. For that reason, my bill removes the sunset, making this a permanent benefit, and a perfect one too, but a permanent benefit. In addition, Senate Bill 1034 addresses several issues raised by consumer advocates that are intended to increase access to treatment. The bill updates the definition of behavioral health treatment to ensure coverage for interventions designed to maintain functioning, which is critical to children with autism. It limits unnecessary treatment plan reviews and clarifies that medically necessary services cannot be denied based on time or location of delivery, primarily school sites. And it ensures that medically necessary treatment cannot be denied based on the ability of a parent or caregiver to, quote, participate in the treatment plan. With me today are several advocates for children representing families and children with autism. Melissa Cortez-Roth from Governmental Advocates, Julie Kornack from the Center for Autism and Related Disorders, and Kristen Jacobson from Autism Deserves Equal Coverage to provide additional testimony in support. Go ahead.
Thank you. Melissa Cortez-Roth with Governmental Advocates representing Autism Speaks and the Center for Autism and Related Disorders. I had the privilege of working on SB 946, the original enacting legislation, and that bill was an incredible step forward for the autism community. It really was the result of years and years of work. Prior to that, before insurance covered these benefits, the state bore the costs. This was provided to some children who qualified through our regional centers and our developmental centers at an incredible cost to the state. We're looking at this bill not as making wholesale changes to the existing benefit, but really we're trying to make the law work. After the bill was enacted, we continue to see denials, coverage limited, wholesale blanket policies that have nothing to do with the individual, but just the plan restricting coverage. So really we're viewing the changes in this bill as not expanding the original mandate, but making the law work. In the interest of time, I'm going to defer the rest of my testimony to the other witnesses.
Thank you. My name is Julie Kornack. I'm with the Center for Autism and Related Disorders. I'm the Director of Public Policy, and we're one of the sponsors of this bill. I want to be clear that this bill does not change the responsibilities of the plans. It clarifies their responsibilities based on what we've experienced in the last few years. Since the autism mandate was first enacted, we've repeatedly encountered efforts by health plans to deny medically necessary treatment because of the setting in which it occurs or because of the time of day occurring during traditional school hours between 9 and 3. Even more troubling, health plans have used a child's school attendance as a reason to reduce medically necessary treatment hours when a child's school attendance clearly has no bearing on medically necessary treatment required to address his diagnosis. For example, health plans routinely try to reduce a treatment plan from 40 hours to 10 to 15 hours because a child is beginning or returning to school. Policies of health plans to exclude services in a school setting have had a chilling effect on access to autism treatment because of the many providers who obligingly follow those policies and as a result fail to request or deliver sufficient hours of behavioral health treatment. Autism treatment is unique in its high number of treatment hours and the need to deliver medically necessary treatment across all natural environments, including school settings. In fact, the location, such as a school or community setting, may be an integral part of the treatment plan and may be necessary to ensure treatment goals are met, especially generalization across settings. Specific concerns have been raised about the scenario of plans paying for services delivered by school personnel to comply with IDEA. This bill does not relieve schools of their obligation to pay for services under IDEA. Plans would continue to be responsible only for medically necessary treatment described in a treatment plan that the plan has authorized and delivered by qualified healthcare providers. In truth, there should not be confusion around this issue. I think it's fairly obvious to most of us when we receive medically necessary treatment versus when we're participating in something related to a school curriculum. This bill eliminates an improper, artificial exclusion that precludes medically necessary treatment from being delivered in a school setting. Ensuring that sufficient services are delivered is cost-effective. When children with autism don't receive sufficient hours of behavioral health treatment, they are less likely to become adults who function independently in the community, and the cost of caring for adults who need full-time support is typically borne by taxpayers. Knowledgeable providers and sophisticated parents with resources are able to overcome the denials of the health plans through independent medical reviews, but average families are left without adequate treatment. This bill redresses this by providing clarification both to the plans and the healthcare professionals to ensure that behavioral health treatment is delivered as the mandate intends, with uniform access to medically necessary behavioral health treatment.
Hello, Honorable Chair and committee members. Thank you for the opportunity to testify today in support of SB 1034. My name is Kristen Jacobson, and I'm founder and executive director of Autism Deserves Equal Coverage Foundation, a nonprofit advocacy organization targeting improved access to healthcare for individuals with autism. Like Melissa, I was proud to be heavily involved in drafting and passing SB 946 over a number of years, and my organization is proud to be one of the sponsors of SB 1034. To support Julie's testimony, my organization has appealed approximately 10 location or time of day denials by health plans. Every single denial has been overturned, either through an independent medical review decision, a reversal once the regulator informs the health plan it's being sent to IMR, or a demand letter from the regulator. But families without our help typically give up. Taking a case to a regulator is burdensome for families. It is complicated, time-consuming, and inaccessible for most families. Our appeals have required dozens of hours of professional advocacy time on top of parent and provider time. I have with me 7 different cases involving 4 different health plans, redacted overturns, which I'm happy to share with the committee. In one particularly egregious case this year, after a health plan had already lost the medical necessity IMR for this family and 2 other families, the plan issued a new denial to the very same family on a specious educational coverage exclusion. The Department of Managed Healthcare issued a demand letter to provide the service on a school site and to make a medical necessity determination, and the plan refused both issues. So while the case has been sent to enforcement, the appeal lasted 10 months and the child never received that treatment. Families should not have to struggle every time to receive this life-changing care, and optimal outcomes should not be limited to those with the means and wherewithal to wage a huge appeal battle with insurers. And many don't even get the chance to appeal because providers don't understand that it's not allowed to be excluded. SB 1034 also includes language to eliminate the improper practice of health plans denying behavioral health treatment based on parent participation requirements. Everyone is in agreement that parent participation in ABA treatment typically optimizes treatment. Of course, it is still extremely effective without parent participation, and effectiveness for a particular child must be shown in any event. Providers will always work to train the parents and guardians, but some parents cannot participate, and the health plans try to impose a requirement that should never be a condition for access to care. Most parents who don't participate can't get time off for work, or have other children whose schedules interfere, or have mental or physical disabilities themselves, such as or are single parents with multiple responsibilities that make participation in treatment extraordinarily challenging. This denial reason disproportionately affects low-income families and families of color. A colleague in Southern California is currently working with a child whose behavioral health treatment has been reduced due to lack of parent participation. The child's mother is holding 2 jobs and is struggling as a single parent. This child still deserves treatment. The Chabert report supports our position and says a preponderance of evidence from studies with moderately strong research designs suggests that parent and caregiver involvement improved outcomes. However, evidence also suggests that behavioral health treatments are more effective than usual care, regardless of the caregiver involvement. We're not adding new requirements in this bill. In addition to these denials being a clear violation of the federal mental health parity law, our state's mental health parity law requires all medically necessary treatment, something that has been confirmed by both the Ninth Circuit Court of Appeals and the California Supreme Court. Behavioral health treatment should not be denied because it's delivered in a church or a school at 9 in the morning, or when the parents have to be at work or taking care of another child. I urge your vote.
Thank you. The time is allotted is up, so if we can ask anybody, just state your name and position, please. Thank you.
Thank you, Chairman Hernandez, members of the committee. Rick Rollins, here on behalf of the Autism Business Association, an association of about 36 autism providers here in California, as well as the Applied Behavioral Consultants, which is a large ABA provider, in support of this bill. Very important on 2 accounts for access, continued in getting better access to families for coverage, and again, the idea of sunsetting the most significant law that's impacted is when we sunset autism, we can sunset this law.
Thank you.
Thank you.
Hi, Karen Fessel, Mental Health and Autism Insurance Project. In strong support, this bill has been so successful that there's a shortage of ABA providers right now able to deliver the services. Thank you.
Kathy Dressler from the Children's Partnership, in strong support.
Tam Law with Health Access and Support.
Thank you. Opposition? The proponents went over by about 1.5 minutes, so we're going to give a total of 7.5 minutes.
Yeah. Tweener, actually. I'll be happy to let the opposition up. But Daniel Savino, Association of Regional Center Agencies, neither in support or opposition. We do have concerns with the bill, though. Our top line concern is to ensure both the quality of service and the quality of outcomes for individuals receiving services. While this bill allows more flexibility in the supervision of in-home staff, it does not specify how many staff members or individuals' behavior programs can be supervised under one professional certification. It is important to ensure this change does not reduce the quality of clinical supervision. The goal of behavioral services is, of course, to improve skills that help people become more functional in their homes and communities. Engaged, participating parents play a huge role in helping individuals to transfer the skills they learn to treatment, from treatment in natural settings. If changes are going to be made to either where services are delivered or the expectations for parent participation, additional details are needed regarding how this skill generalization will be accomplished. We very much appreciate the author's longstanding commitment to the diverse community of people with developmental disabilities, as well as this bill's removal of a sunset for SB 946. We also appreciate our ongoing communications with the bill's sponsors. We look forward to continuing these conversations in coming weeks towards our shared goal of ensuring all individuals with autism spectrum disorder have access to the quality, effective behavioral health treatment they require.
Thank you. Those in opposition, please proceed.
Good evening. I'm Jennifer Alley with California Association of Health Plans. Our members currently provide medical and applied behavior analysis, ABA services to their enrollees with autism. In fact, there's actually 3 autism bills that are going through the legislative process now, and we have an ongoing autism work group to kind of identify what health plans need to ensure an adequate network and availability of providers in the state to provide this service. We're actually supporting, in a supportive amended position in a bill in the Assembly that creates a licensing structure for ABA providers. It provides 3 levels of care, and how plans would benefit from a licensing structure being in place is that there would be, it would be easier to certify the networks and a process in which we can file complaint with if there's any issues with the quality of treatment that's being provided. And so I just want to be very clear that initially when 946 was passed, CAP, prior to my tenure there, was opposed to it. Since then, we've moved forward with the ACA with inclusion of autism as a behavioral health benefit under mental health parity, and our members are providing it, and we're looking to figure out how we can do it even better in certifying and building our networks. And so we're opposed to this bill today, not because we don't want to see the sunset removed for autism care. We actually support that. We have more concerns around how the bill expands the existing coverage requirements, specifically the time and location issue. Time and the ability to access timely care is something that our regulators take very seriously. And when a family is able to designate a specific time, that might cause us to miss the timely access. If everybody wants 6 o'clock on Wednesday nights, then how can we ensure that we have an adequate network for that time slot? And so the ability to manage access to care when you look about any time being desired by the patient receiving the care, that becomes a problem for us in the ability and how we build that. As for location, my members have reported to me that we currently, on one-off cases and special instances, do provide services in schools. However, there's historically been a very hard red line between health plans providing services in a school setting. There's multiple hundreds of school districts in the state. The providers have to get the approval to it. It's just not something that health plans have been required to do before. And so we're very concerned about how that would open up a slippery scope of health plans providing healthcare services in school when there's special education funding currently available for that, and the impact that will have on our members and their ability to keep premiums low. We also, our members really believe that through their experts and their provider network, that when parents participate in the care of their children and they're trained in the use of the tools that are developed during ABA therapy, that care is more effective and has higher and more successful outcomes. And so we would question why we would not be able to require that if there's an issue in developing and maintaining treatment goals. Go ahead.
Good evening. Sherry McHugh, representing the California Chamber of Commerce. Well-intentioned, we are very concerned that this bill will add to the rising problem of the rising healthcare costs in the system. Employers are trying their best to provide coverage for their employees, and we are concerned that this could further hinder employers from doing so. With that being said, we are committed to continuing to work with the author and the sponsors in an effort to see if we can address our concerns. Thank you.
Megan Loper, on behalf of the Association of California Life and Health Insurance Companies, I would echo the concerns of my colleagues.
Yeah, John Winger, on behalf of America's Health Insurance Plans, we'd like to associate our comments with CAP.
Thank you. Anyone else in opposition? Questions, comments? Senator Roth?
Just a question of the author. Perhaps you could comment on the, if I describe it correctly, the adequacy issue of everybody wanting 6 p.m., and also the interface between the special education funding and what's required under this bill.
Thank you very much for the question. I appreciate everybody wanting 6 p.m. because as a working parent myself, I wouldn't have had to leave committee today for a 4:15 meeting at my son's school if I had had an option to have a school meeting after today's hearing was over, but I didn't have that option. I think behavioral health services and the whole notion that they are in any way similar to special ed education services or any services provided by a school district, a school employee, in a school setting is naive at best. The reason to have flexibility on location of provision of services is because of the unique experiences and characteristics and needs of the kids in the autism spectrum. So having the services delivered at home or at school, settings where they are comfortable, settings where they need behavioral health assistance to be able to learn how to navigate those settings is what the true nature of these services are. And so it's not about the location of the service, it's the nature of the service itself. And so just because it's at school doesn't mean it can be provided by a school district employee. You follow me? I appreciate the challenge with regard to the 6 o'clock, but we're dealing with parents who are having to manage multiple services and resources, sometimes for multiple children. I don't know that everybody will request 6 o'clock on Thursdays. I appreciate that. But we have to deal with the realities of what these families are facing, their work schedules in all honesty. And I'm sure that parents will be accommodating. If 6 o'clock's not available, they'll go on with the next available appointment. I don't know if the language in this bill will necessarily create the bottleneck that the opposition, with all due respect, suggested.
With respect to the services provided on school grounds, who's the gatekeeper for that? Who decides who does what, schools versus health plans? Is that an intelligent question?
Any question from you, Senator Roth, is intelligent?
I wouldn't go that far.
Do you understand the question? The behavior.
Yeah, I did understand the question. So the health plan is going to need to determine the medical necessity of the services that are being requested on the school site. The issue is about medical necessity. A health plan can still deny any service on whether it's medically necessary or not. The school is going to be deciding what services are educational.
Which would be included in an IEP.
Which would be included in an IEP. If there are anything that possibly overlap, then there would be collaboration. But it's very clear in this bill, the school still is responsible for providing and determining what's educational, and the health plan is responsible for determining what is medically necessary for the patient. If they want to deny it, they can. We're just saying you can't deny it just because it's at school. If you want to deny it, you have to deny it because it's not medically necessary. And then there's a mechanism for that. The other thing is we're not asking for treatment at 6 o'clock. We're actually saying, please don't deny treatment just because it happens to be at 9 o'clock. It's completely the opposite. It actually expands when treatment can be available, because right now I have denials that say we will not cover any treatment between the hours of 9 and 3, regardless of where the child is, even if you are at home. And that's what we're actually trying to prevent. It's completely the opposite. It would open up 8 more hours in a day to actually allow network adequacy.
I stand corrected on the timepiece.
Thank you. Anyone else would like to, any questions, comments? We have a motion by Senator Manning. Would you like to close?
Thank you very much, Mr. Chair and colleagues. I would just say that a number of us have heard perhaps hundreds of hours of testimony from parents and advocates between the Budget Committee hearings on when we eliminated Healthy Families, and this was a covered benefit in Healthy Families, and we were talking about the challenge of making sure that once we eliminated the program, those children moved into Medi-Cal if this service would continue. I served in the Select Committee on Autism under Senator Steinberg. Again, hundreds of hours of testimony. I can say unequivocally that there is no parent of a child with autism that doesn't fully understand the role they must and should play in their behavioral health experience. I can also stand here and say that I had the luxury as a state senator to leave today at 4:15 to go to a school meeting, and many working families do not. So it's not about they choose not to be engaged in the behavioral health service delivery. For many, it's they can't, or they can't consistently. And so to deny that service because someone has determined that the parent won't be involved at every experience, I think is unfair and denies the parents' commitment to their children and their desire to have their children improve. There was a concern expressed in the analysis by ARCA, and I'd just like to say that supervision will be diluted with the new language. Their concern was that supervision would be diluted with the language in the bill. It is our argument that qualified autism service providers are responsible for the QAS professionals and QAS paraprofessionals they supervises. They jeopardize their own license and our certification if they provide insufficient supervision. Moreover, health plans authorize and track with separate billing codes. I think between the opponents, we've attempted to address all the arguments that we felt were valid and reasonable expressed by the opposition. We will, of course, continue to work with them to provide clarification. As many proponents argued, this bill was a long time coming, involved many of those who work in the field at the community level. It was a reasonable expectation to ask that a sunset be included in the bill in 2011 because we wanted to get past Affordable Care Act. We now have that information. We have some experiential history also in terms of what's working and what's not working. We thought it was reasonable in this bill to eliminate the sunset to benefit from our experience so far since 2011 in administering this relatively new program. And with that, I ask for your aye vote on the bill.
Thank you. Senator, I know you made some reference to the amendments. I just want to clarify, we do have a mock-up in front of for everybody. However, I want to note, just to bring attention to you, is that on Section D, subsection II, there was a misspelling, so it says, time of treatment shall not be sued as a reason to deny, and it should be used. So I just want to clarify that, because otherwise, we don't want to.
Open it up to us lawyers.
Right.
Used, not sued.
Sued, yes.
Yes.
The word is used. So with that.
Amendment, friendly amendment accepted by the author.
Just because of typo, and
Yes.
I won't say who made the typo.
Yes, thank you.
Me, it was me.
So
Ask for your aye vote,
we
sir.
have item number 4, SB 994, do pass as amended to appropriations with the appropriate spelling. Call the member, SB 1034, I'm sorry. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Hall, aye. Mitchell.
Aye.
Mitchell, aye. Monning. Monning, aye. Nielsen. Pan. Pan, aye. Roth. Roth, aye. Wolk.
That currently has 6, enough to get out. I think everybody left that's going to leave, so that bill is out.
Okay, thank you.
That's the first bill out. So we're going to move to the consent calendar. Item number 6, SB 1100, call the absent members.
Hall. Hall, aye. That's out.
Okay, that bill is out. We're going to start off with item number 1, SB 932, call the absent members.
Hall. Hall, aye. Nielsen. Pan. Roth. Roth, aye. Wolk. 5-1.
That's 5, and that bill is out. Item number 2, SB 960, call the absent members.
Nguyen. Hall. Hall, aye. Nielsen.
6-0, that bill is out. Item number 3, SB 994, call the absent members.
Hernandez.
Aye.
Hernandez, aye. Nguyen.
Oh. I don't know for Hernandez.
I don't know. Hernandez. Nguyen. Mitchell. Nielsen.
Wait,
Mitchell.
Go ahead. Current vote count, item number 3, current vote count is 5-1.
Mitchell, I.
Current vote count is 6-1, and that bill is out. Item number 5, SB 1098, call the absent members.
Wynn, I. Mitchell, I.
Current vote count is 9-0, that bill is out. Item number 7, SB 1113, call the absent members.
Hall, I.
9-0, that bill is out. Item number 8, SB 1189, call the absent members.
Hall,
6-2, that bill is out. Item number 9, SB 1283, call the absent members.
Wynn, I. Hall, Mitchell, Monning, Pan, Roth, Wolk.
Current vote count is 2-1, that bill fails. Is there a motion for reconsideration? Move to reconsideration. Item number 11, SB 1339, call the absent members. Item number 10, SB 1300, call the absent members.
Wynn, Nielsen, Roth, Wolk.
Current vote count is 5-0, that bill is out. Item number 11, SB 1339, call the absent members.
Hall, I. Mitchell, I. Nielsen, Roth, I. Wolk.
Current vote count is 7-0, that bill is out. Item number 12, SB 1365, call the absent members.
Nielsen, Roth, Wolk.
Current vote count is 5-1, and that bill is out. Item number 13, SB 1384, call the absent members.
Wynn, I. Hall, I. Mitchell, I. Nielsen, Roth, I. 8-0.
Item 80, that bill is out. Item number 14, SB 1420, call the absent members.
Hall, I. Mitchell, I. Nielsen, Roth, I. 8-0.
That vote count is 8-0, that bill is out. Item number 15, SB 1471, call the absent members.
Nielsen, Wolk.
Current vote count is 7-0, and that bill is out. And that concludes the business of the day, and we are adjourned.